This one starts like a pretty straightforward asthma story. A 25-year-old woman with asthma is exposed to cleaning chemicals at work and suddenly develops severe shortness of breath, wheezing, and chest tightness. She's in serious respiratory distress. So she gets what we'd expect: continuous nebulized albuterol and IV methylprednisolone. And it works. A few hours later, her breathing is much better. But then something else starts happening. She develops muscle weakness. She's having trouble lifting her arms over her head, and she has a little hand tremor with decreased deep tendon reflexes. That combination is interesting because the lungs are getting better, but now the muscles aren't working quite right. And this is where albuterol becomes really interesting. We usually think of albuterol as simply a bronchodilator. You give it, the beta-2 receptors relax bronchial smooth muscle and the airways open, but beta-2 stimulation has another effect that can become important when the dose is high. It stimulates the sodium-potassium ATPase pump, which shifts potassium from the blood into cells, so the serum potassium starts to fall. And that's hypokalemia. Now, those symptoms make a lot more sense. Low potassium can interfere with normal muscle function, so patients can develop muscle weakness and decreased deep tendon reflexes. And the tremor? That's also a familiar effect of beta-2 stimulation from albuterol. So suddenly, we have a very neat little picture. A patient receives a large amount of albuterol, potassium moves into cells, serum potassium falls, and she develops weakness and hyporeflexia. And there's one more thing I like about this concept. The potassium level can be completely normal before treatment. Then, after a large amount of beta-2 agonist, it can change. So if someone develops new muscle weakness after intensive albuterol therapy, it's worth checking the serum electrolytes again. And because significant hypokalemia can affect cardiac conduction, an ECG is important too. You may see things like flattened T waves and prominent U waves. And if the hypokalemia is significant and symptomatic, you replace the potassium. So the next time you see a patient receiving a lot of albuterol, don't just think, okay, bronchodilator. Remember that beta-2 agonists can also push potassium into cells. And if the patient suddenly develops weakness, hyporeflexia, or that familiar tremor, think about what just happened to the potassium. And that's the little detail about albuterol that's easy to miss, but really worth remembering.